to agree, and I'm really grateful to him. After a career in the government service for over 33 years, he was a consultant for 24 years. He left the Ministry of Health to work full-time in the private sector. Now he works as a consultant physician at the Derby's Hospital, Colombo. He served as a director on the board of the Lanka Hospital Corporation from 27 February 2012 to 24 February 2015. And he was later appointed to the board of Derby's Medical and Surgical Hospital in 2017. He has been associated with the Faculty of Medicine, University of Colombo, and the Postgraduate Institute of Medicine, University of Colombo. He has taught many undergraduates from the faculties of medicine at Kelaniya, Sri Jayawardena, and Colombo. He trained many postgraduates through the PGIM, Colombo. He held many positions at the PGIM. He was on many occasions the chief examiner of MD Medicine and chairman of the MCQ core group. He was president of the Ceylon College of Physicians in the year 2005, and that year marked an important development in the medicine sphere in this country, where to the College of Physicians, he introduced a set of guidelines for clinical practice, and it was quite extensive. I remember listening to his induction speech that year, and where he proposed making those guidelines, and they became a reality very soon in that year. And I think to this date, we practice the guidelines initiated by him. I think that's a great contribution he made to the field of medicine in this country. He had a very active academic career and as a busy physician, and worked as a physician in both the state and private sector. And he has many publications in both the national and international peer-reviewed journals. There are too numerous to mention here. And he received a Presidential Award for Clinical Research in the year 2000. And in recognition of his contributions to the field of medicine, he was awarded honorary fellowships by the Royal Australasian College of Physicians and Colleges of Medicine of South Africa. And he is also a fellow of the American College of Physicians and Ceylon College of Physicians. He was awarded the Vidya Jyoti title in the year 2019 in recognition of his contribution to the field of medicine. And he has many peer-reviewed publications in journals, and he has delivered over 28 lectures at local and international fora. And on a personal note, he has been a mentor to me over the years, and I have been associated with him both at the National Hospital and at this hospital. In fact, I had the privilege of looking after his board until he was able to get the transfer from Colombo Hospital to National Hospital. So, I think our careers have been linked. So it's quite fortunate that I've been able to introduce today. And I think without any further delay, I would like to invite you to deliver this very important talk. As Ganaka said, we as physicians have to learn from the seniors, and I think there are many physicians listening to following this lecture today, and I'm sure they will gain a lot. And this indeed is a very important aspect, important part of our yearly program. Audience.
Good morning, everyone. Thank you, Harsha, for that very kind introduction. And let me thank the President and the Council of the College of Internal Medicine for inviting me to give this lecture today. And in fact, they invited me to give a lecture at the annual session about a year ago. At that time, I was busy with some other commitment. I'm sorry I could make it. I think from that time onwards, I have been thinking of coming here and giving a lecture to fulfill my commitment. So let's start the lecture. It's the title, Back to Basics, Think Simple. So as we know, we cannot build on anything if you don't go by the basics. So at the end of the lecture, you will realize what actually I mean by going back to basics and thinking very simple. And right. So this, what do you actually mean by a legend? I was going through the Oxford Dictionary to find the actual definition of a legend. Supposed to be a very famous person, especially in a particular field, who is admired by other people. Then who is a veteran? A person who has had long experience in a particular field. I consider myself to be a veteran more than a legend. Okay, so we are all physicians in internal medicine. Now, internal medicine is becoming more and more relevant with subspecialization. Subspecialties would only be interested in their own field. So if it is a chest pain, immediately the person would be referred to a cardiologist who would do an ECG, echo, troponin, and a TMT, and they lose interest afterwards, right? If all these things are negative, then the patient would come to a general physician. Right. Okay. Now, for example, I have seen so many patients being referred to or coming to me after being seen by cardiologists. This is not intended to insult anybody. This is the reality. I've seen a patient, for example, somebody who was referred to me from the cath room, so the cath lab, with a hemoglobin of 6.5. So that this patient's anemia, angina was actually due to anemia, and it was detected at the time of coronary angiography. Right. And then number of patients with thoracic herpes, right? Especially these days, people are very reluctant to remove clothes because of COVID situation, and they like to keep the distance. And patients presenting with chest pain and doing ECGs, echoes, and also exercise ECGs sometimes, and the herpes being missed because you don't undress enough to see the skin or the thorax, right? Unless it's a very important lesson for us to learn, right? Anybody with chest pain, especially in the before the rash appears, it can be impossible or extremely difficult to diagnose. But sometimes you see little red spots, right, before the vesicles appear. So it's very important, anybody coming with a chest pain, particularly, is confined to one side, to remove the upper part, expose the upper part, and carefully look for vesicles, early vesicles of herpes. I have seen a number of patients. So I was trained by late Professor Dharmadasa. I think everybody knows who Professor Dharmadasa is. He used to say one day there would be separate physicians for the left hand and the right hand, and we are almost there. Right, and he said went on to say that right hand physician would not look at the left hand because his field is only the right hand. And so we are realizing more and more that we need people who would look at patients or would have an holistic approach to patients rather than looking at the heart by the cardiologists, or the lungs by the chest physicians, or joints by the rheumatologists. I think they have absolutely a place to play. I think the screening or initial consultation is done by a physician in internal medicine. I think most of these problems could be avoided because we look at the patient as a whole. We all have a holistic approach. So other thing is, we internists should not be influenced by or carried away by the diagnosis made by subspecialists. Now there's a tendency for us to look at the suggestions made by, for example, hematology. You send a blood sample for a blood picture, and that person recommends 101 investigations. And mind you, this person has not even seen the patient. So our tendency is to, a lot of people tend to follow those instructions and do everything that they recommend. And the hematologists, I'm not trying to insult them or something, right? But they haven't even seen the patient. Most of the time they are lab-based. And we should always look at patients with an open and unbiased mind. Don't be influenced by or intimidated by big names, right? Everybody makes mistakes. And the big names are more like to make more mistakes. They are busier than other people. So as medical students, we were taught about history, examination, and then investigation. And even if you go to the top of the ladder, these things still apply. The most important, even in this high-tech era, the history and examination, one cannot proceed without a relevant, good history and a focused examination. Even if I am rushed, I will still spend about 80% of the available time on the history, because with the history, good history, 80% of the match is won. You get most of the information from the history. So if you have 5 minutes, spend about 4 minutes on the history. And ideally, a head-to-toe examination, but not practical in day-to-day life. So what is the alternative? With the proper history, one can do a relevant focus examination. If you take a good history, you know what to look for and what to examine. And that's very important because that saves time and gives more information. So I have seen this trend of getting pre-intern to take history and do the examination. That's the latest trend. Seen a lot of consultants, senior consultants getting pre-interns. The first contact is the pre-intern. The person walks in, there's a room adjoining the consultant room, especially in the private sector. And the history and the examination part are done by the pre-intern. And then the patient walks in to the consultant's room. The most difficult task is given to the least experienced. You know how difficult it is to take a focus history. You know, as teachers, we used to listen to the histories taken by the third-year medical student, first medical appointment. I remember classic history. So this patient was admitted had developed fever about 3 days ago. He went to the GP, and the GP gave some tablets and a lotion to apply because there was a little skin rash, and a cough syrup because he had a little bit of cough. And he, after 3 days, because he was not getting better, he went to the local hospital in Homagam. Right there, again, he was examined by the OPD doctor and ordered some investigation, gave some pills. And then 3 days later, because he was not getting better, was admitted to the hospital. After 3 days, because the patient was not getting better, he was transferred to General Hospital, Kalam. So that is the typical history. So we don't actually, so now this kind of most difficult, when you give that task to the least experienced person, you know what the results are going to be. And the specialist goes through the reports and try to work backwards to arrive at a diagnosis. And specialists write only the prescription, right? Even that is sometimes done by the intern, right? He dictates and the prescription is written. It's all done digitally. And even if you are the best, if you think you are the best, you still have to stick to the basics. Relevant history and focus examination. Then think of a differential diagnosis and ask for relevant investigations. And importance of estimating is very important, asking for the relevant investigation. Then we have to consider this importance of estimating the pre-test probability. For example, if somebody comes with aches and pains, it's a very common practice to ask for a rheumatoid factor, right? So the rheumatoid factor can be positive in a certain percentage of normal population, right? If you don't estimate, say if the clinical picture, the history and the examination are not compatible with, for example, rheumatoid arthritis, there's absolutely no point asking for a rheumatoid factor because certain percentage of normal people have a positive rheumatoid factor. So even in the presence of, now I'll go to one step further later. So then one has to critically evaluate the test results. No point in asking for results, the investigations. Once you get the results, one has to critically evaluate the results and re-examine in the light of results of the investigations. Right? You have to always go back to the examination. And this is to get some idea about the pre-test probability of a test. Now, this is regard to angina. So there are three categories of chest pain: typical angina, atypical angina, non-angina chest pain, right? And different age groups are given: 30 to 39, 40 to 49, 50 to 59, then 60 to 69. And the result, the positive results are the ones that are being confirmed subsequently through angiography, right? 30 to 39 with non-angina chest pain in men, that group had only 4 positive. On the other hand, 60 to 69 group, if the patient had typical angina, the likelihood of having angina or ischemic heart disease is about 86%, right? And it's very, now even if the test is negative in that age group, it's very likely that the patient has coronary artery disease. On the other hand, 30 to 39 group, right? And if the patient has a non-angina chest pain, even if the test is positive, it's very likely to be a false positive test. So what they say is the 20 to 70 group, the intermediate group, only the ones that require further investigation, right? More than 70%, you can proceed, you can accept that it is, even if the test is negative, then you know it has to be a false negative. Then you go on to the next step. If it is less than 20, even if the test is positive, you know that it's going to be a false positive. So you don't proceed further. So unless you know the pre-test probability, you can never interpret the post-test probability. So no point asking for tests, especially things like rheumatoid factor, ANA, very common. Every patient with aches and pains, you ask for these investigations. So I will now give you a few examples of where the things went wrong, horribly wrong, due to not following these basic rules. Now, ascites is a very common problem. I think everybody sees about at least 2-3 patients a week now. So we try to understand the basic pathophysiology because it's very important to understand this. Then only you can do a differential diagnosis and come to a proper diagnosis. So we know portal hypertension is the commonest, then hypoalbuminemia, peritoneal disease, and other etiologies rare like chylomicrosis, pancreatic, and mixed edema. And out of these, cirrhosis is the commonest. So 80%, cancer 10%, heart failure 3%, others are uncommon. So you can, if you can close your eyes and make a diagnosis of cirrhosis, and you are going to be right 80% of the time, right? So anybody coming with ascites, if you say it's due to cirrhosis, is portal hypertension, you are right 80% of the time. But it's okay for you, but that 1% of patients who don't belong to that category is going to be a disaster. where some of these things are treatable and curable. For example, cirrhosis, portal hypertension, by the time they develop ascites, almost 50% of will be dead in another 2 years. So with some cirrhosis, portal hypertension and ascites, they carry a worse probability than some other cancers, right? So if it happens to be a tuberculosis, right, or pancreatic disease, you can easily, over some of the time, sometimes you can treat them. Right. So ascites due to portal hypertension, as I said, it can be the ascites due to portal hypertension can be cirrhotic or non-cirrhotic. So the most of the time we diagnose cirrhosis, we tend to forget about the non-cirrhotic causes. No, non-cirrhotic portal hypertension is a very important category and can be easily misdiagnosed as cirrhosis. And there are many causes, pre-hepatic, intrahepatic, and post-hepatic, as medical students and interns, undergraduates, postgraduates, at every level we have studied. And the important thing is this entity is often forgotten. That's called non-cirrhotic portal hypertension. As I said, it can be pre-hepatic, intrahepatic, and post-hepatic. I'm not going to go into details. Intrahepatic, pre-sinusoidal, sinusoidal, and post-sinusoidal. And these are the common causes: pre-hepatic portal vein thrombosis, splenic vein thrombosis, splanchnic AV fistulae, splenomegaly from lymphoma, Gaucher's disease, that kind of thing. Then intrahepatic, pre-sinusoidal, sinusoidal, and post-sinusoidal. Pre-sinusoidal, developmental abnormalities, then biliary diseases, neoplastic occlusion of the intrahepatic portal vein, granulomatosis liver disease, and idiopathic non-cirrhotic portal hypertension, or INCPH. It's a very important category, and we are going to discuss a little bit in detail. Right. So what is the general approach when you find a patient has ascites? So we have a first general approach. I'll come to that later. An initial acidic fluid test, that is clinical macroscopic appearance to see whether it's clear, bloody, or cloudy, or milky. Clear means then we have to do further investigation. Bloody, then you know it's either malignancy or TB. Then cloudy, infection, and milky, increased triglycerides, chyluria. Then the most important, one of the most important determination is the serum to ascites albumin gradient, or SARC, and the cell count and differential and total protein concentration. Then other more uncommon test. Now, before we go into test, one has to take a history and see if there's any, because cirrhosis being the commonest, one has to take a history to see if there's any evidence of cirrhosis. Look for stigmata, that is gynecomastia, your usual things, palm erythema, parotid enlargement, and then spider nevi, right? So those are the general things. And then at the same time, look for any history suggestive of malignancy or history of malignancy. See a breast, see a lung, and also evidence of heart failure or persist or tuberculosis. Right. Now, we used to learn and teach as well, medical students as well as teachers. The first important thing is to find out whether ascites is out of proportion to peripheral edema. Right. It's very basic, but very commonly missed, and you don't pay much attention. Right. If there is the ascites is out of proportion to peripheral edema, it is cirrhosis, either cirrhosis with portal hypertension, or intraperitoneal malignancy, or intraperitoneal infection like TB, or constrictive pericarditis. I think 4 things we used to learn as medical students. It's still valid. And if the JVP is elevated, right, it's very unlikely to be cirrhosis. It is only elevated when there's tense ascites and increases the intrathoracic and intra-abdominal pressure. And so when there is associated pulmonary hypertension, portal pulmonary hypertension is a recognized entity, and or if there is any concomitant renal insufficiency giving rise to increased fluid retention or increased intravascular volume. But if you have a patient with ascites, which is out of proportion to peripheral edema, always think of heart failure, constrictive pericarditis, and restrictive cardiomyopathy. It's very important. So if the JLP is not elevated, then we need to find out whether there is any portal hypertension, right? Or the second step is the fluid infected, right? So we mentioned ascites or cirrhosis, portal hypertension, and then intra-abdominal malignancy, intra-abdominal TB, and then heart failure, that category. So tests performed on acidic fluid, I mentioned that earlier, generally routine test, cell count, albumin concentration, and total protein, then the others are optional tests. Now, out of these, the most important one is other than that is cell count, the SARC, or acidic fluid, serum acidic fluid, albumin gradient. If it is more than one, we all know that indicates presence of portal hypertension. If it is less than 1.1, that means there is no portal hypertension. When you say portal hypertension, it can be due to cirrhosis, alcoholic hepatitis, heart failure due to increased blood pressure, and passive hepatic metastasis distorting the architecture of the vessels, and then heart failure, constrictive pericarditis, but carry portal vein thrombosis and idiopathic portal fibrosis. All these conditions are associated with SARC of 1.1. The important thing is that here you can make two diagnoses. That is, if somebody has heart failure and TB, peritonitis, or heart failure and cirrhosis due to ascites due to cirrhosis, portal hypertension, you can differentiate. For example, if there is elevation of SARC more than 1.1, we know there is portal hypertension. But if that person happens to have high total protein content in the acidic fluid, say more than 2.5, then we know there is an additional issue, because in cirrhosis, when the pressure in portal hypertension, total protein content is always less than 2.5. So these are very detailed. I am not going to go into details how to analyze or approach ascites. Now I'm going to present 3 patients who have been misdiagnosed as cirrhosis. Patient 1, 65-year-old lady diagnosed as cryptogenic cirrhosis by a specialist gastroenterologist. Came because she was not getting better. She had generalized edema, dyspnea, and anorexia. Examination showed generalized edema with elevated JVP, moderate ascites, right-sided pleural effusion, but no peripheral stigmata of chronic liver cell disease. Serum albumin 3.5, ALT, AST marginally elevated, and normocytic normochromic anemia 10.5, hemoglobin of 10.5, normal WBC, DC, and platelets, normal creatinine. And upper GI endoscopy showed mild portal gastropathy and early varices. Now, just to take you through some basics of edema formation, it's very familiar. First lecture by Professor Carl Fonseca on the milieu interior, right? You have the capillary, arterial end, and the venous end. And at the arterial end, hydrostatic pressure is higher than at the venous end. And as a result, the fluid leaks out of the capillaries. And at the venous end, the opposite way, the fluid comes back into the capillary. And a little amount remains as interstitial fluid, and part of it is carried by the lymphatics. Now, we are all familiar with this figure. At arterial end, the pressure is hydrostatic pressure 37, at the venous end 17, and oncotic pressure is 25. And at the arterial end, the 37 minus 25, it is 12 outwards, and at the venous end, 25 minus 17, 8 inwards, right? So see how where the things can go wrong. If the hydrostatic pressure, the arterial end goes up, obviously the more fluid will leak out. But that has happened in normal practice because there's a structure called precapillary sphincter that protects the capillaries at the arterial end. But in certain situations, say for example, these arterial dilators, antihypertensive drugs can cause dilatation of the precapillary sphincter as well, arterial. As a result, the pressure can go up at the arterial end. And also after a stroke, right, there can be damage to precapillary sphincter. So when the suddenly pressure goes up, that because the mechanism is not there, fluid can, the hydrostatic pressure can go up at the arterial end, the fluid can leak out, giving rise to cerebral edema. So at the venous end, right, or if there's an increased capillary permeability, the fluid can, more and more fluid can leak out. So if there's a reduction in colloidosmotic pressure, again, the more fluid will leak out. Or at the venous end, there is an increase in hydrostatic, generalized increase in the hydrostatic pressure, as in heart failure, and also in situation where there is increased fluid retention, giving rise to expansion of the intravascular volume, as in CKD with fluid retention, right? So it's either due to a reduction in colloidal. If you have generalized edema, it has to be either reduction due to reduction in colloidosmotic pressure or generalized increase in the hydrostatic pressure at the venous end, or generalized increase in the capillary permeability. Sometimes we see that in, for example, in dengue fever, dengue hemorrhagic shock syndrome, fluid leaks out. You have fluid in the pericardium and in the peritoneal space and also in the pleural space. So based on this, so it's very important to remember this basic thing, then you can work out a lot of things with regard to edema formation. So if there is generalized edema with elevated JVP, then there has to be a generalized increase in hydrostatic pressure. So that can happen with heart failure, constrictive pericarditis, and fluid increase in the intravascular volume as a result of, say, end-stage renal disease or similar conditions. Right. So obvious clues against diagnosis of cirrhosis in this patient. The patient had generalized edema with an elevated JVP, indicating high right atrial pressure. So that means heart failure, volume load as in end-stage renal failure, right? And intravascular is reduced in cirrhosis. Intravascular is reduced generally in cirrhosis. Hence, the JVP is not elevated. It can be elevated if there is tense ascites or pulmonary hypertension or concomitant CKD. Only slight reduction in albumin and normal platelets. So increased JVP, only slight reduction in albumin and normal platelets. We know that generally platelets are reduced in pulmonary portal hypertension. This patient didn't have, albumin was almost normal and the JVP was elevated and platelets were normal. So ECG showed generalized T-wave inversions. Chest X-ray I will show you, and the echocardiography. And this is because the JVP was elevated, I was thinking of heart failure really, right? And so actually there are two conditions, heart failure and constrictive pericarditis. This is what the X-ray showed. I think we can see what is there. This ring-like thing, right, is the calcification in the atrioventricular sinus groove. And you can see some calcification near the diaphragm as well. You have a point there. Okay. So this is obviously a case of constrictive pericarditis, misdiagnosed as cirrhosis. And this is the CT reconstructed. You can nicely see the ring of calcification in the atrioventricular groove. And the echo, in fact, to be fair by the cardiologist, even CT we did later, soon after the chest X-ray, I sent him for a person for an echocardiography, and he confirmed, I didn't give any details, right? And he confirmed the presence of echocardiography, constrictive pericarditis. And this patient was sent for surgery to the thoracic surgeons. Only thing is there was a delay and they were not really willing to undergo surgery. It took about a year, I think, for them to go for surgery for pericardiectomy, but she didn't survive the surgery. Right? She died, I think, a few days after surgery. Second patient. So the important lesson here, if there is anybody with ascites and ascites being out of proportion to peripheral edema and the JVP is elevated, always think of constrictive pericarditis and heart failure. Right? If you are not on the lookout, you are not going to this. And the thing is, then this patient invariably will go to a gastroenterologist or hepatologist, and once a diagnosis is made by them, diagnosis of cirrhosis with portal hypertension and ascites, nobody will ever challenge that. Right? For the rest of their lives, they will carry the same diagnosis. And this patient, this lady, had the generalized edema with massive ascites, again out of proportion to leg edema. Albumin 3.6, ALT 48, 52, alkaline phosphatase normal, platelets and platelets are normal, SARC was less than 1.1. So this straight away tells us it is not, there is no portal hypertension. SARC is less than 1.1. And he is, again, the specialist gastroenterologist and hepatologist, he did the right things. He did the diagnostic stuff. It showed high total protein concentration, lymphocytosis, and abdominal cyst suspicious of malignancy. Right? And what did he do next? He went and did a upper GI endoscopy. So his diagnosis cirrhosis, he is trying to justify cirrhosis portal hypertension. So he went in to do upper GI endoscopy. And he showed mild portal gastropathy. If you know, whenever you send a patient for upper GI endoscopy, you never get a negative, right? It's either mild antral gastritis, right? Or mild portal gastropathy. When I'm in doubt, I always show these pictures to Professor Janakati Silla, right? I feel I am more comfortable with him because he's basically a first-year general physician and who has a special interest in gastroenterology. And he immediately said, there are no evidence of portal gastropathy, right? And he was so preoccupied with his diagnosis, consultant of cirrhosis, he totally ignored the findings in the paracentesis, right? Acidic fluid, obvious lymphocytosis, abdominal cyst, suspicious of malignancy, and he himself had underlined also suspicious of malignancy. And he did all the right things and made the wrong diagnosis. That is because of wrong interpretation. So whenever I come across a thing like this with regard to gastroenterology and hepatology, I always tell Professor Janaka, because he's the one who has trained most of the gastroenterologists. So he's in a position to advise them, right, not to, without disclosing the names, right, and in a position to advise them because these people are very busy, right? And as I told you, 80% of the time you are right, because it's cirrhosis. And this is another situation where things went wrong. And the CECT abdomen didn't show any evidence of malignancy. CA125 was very high. Diagnosed laparoscopy didn't reveal any ovarian CA. Biopsy revealed primary peritoneal carcinoma. This is something that is extremely difficult to diagnose because CA125, then you always suspect ovarian carcinoma. But when you do laparoscopy and even, CT, laparoscopy didn't show anything. So only the biopsy showed primary peritoneal carcinoma, very similar to ovarian CA, and the CA125 can be also very high. And especially when you don't see anything, you have to do a diagnostic laparoscopy. And that will also will help to diagnose if there is any TB. Third patient, 50 years, 61.8 kilograms, type 2 diabetes mellitus, and he presented with hematemesis on the 9th of January this year, and he was found to have splenomegaly and low platelets. And upper GI endoscopy showed portal gastropathy and esophageal varices, which were banded on two occasions. ultrasound normal liver, normal albumin, and other liver functions. And diagnosed as cirrhosis with portal hypertension. What is against? Right. There are no doubt the patient has portal hypertension, but the liver cirrhosis, absolutely no evidence to suggest. Ultrasound absolutely normal, liver normal albumin, and other liver functions are normal. So we normally go by the ultrasound initial to see evidence of cirrhosis. So though this patient was diagnosed as cirrhosis with portal hypertension, it is obviously not a case of cirrhosis with portal hypertension. You must remember there are many other reasons for portal hypertension. Cirrhosis is just 80%, but in 20% is due to other reasons. The commonest is cirrhosis in 80%. There are many other causes, right? And then we come to this very important entity called idiopathic non-cirrhotic portal hypertension. And it requires so many conditions to be excluded. We know to diagnose cirrhosis, when we come across patient with cirrhosis, we do hepatitis B, hepatitis C, antibodies and ferritin, and look for Wilson's disease and iron overload. We do all that, right? And through that, all those things have to be excluded, right? But in addition, this particular, to diagnose particular entity, you have to have certain criteria. First, of course, the clinical signs of portal hypertension, then exclusion of cirrhosis on liver biopsy. So you have to do a liver biopsy and exclude cirrhosis. In a situation like that, where there is no evidence of cirrhosis on the ultrasound and biochemically, this was a definite indication for doing a liver biopsy. And exclusion of chronic liver diseases that may cause either cirrhosis or non-cirrhotic portal hypertension. These include, as I mentioned, chronic hepatitis B and C, and non-alcohol-associated steatohepatitis, alcohol-associated steatohepatitis, autoimmune hepatitis, hereditary hemochromatosis, Wilson's disease, primary biliary cholangitis, and exclusion of other conditions that may cause non-cirrhotic portal hypertension. Example, congenital liver fibrosis and sarcoidosis. And you have to demonstrate that the portal vein is imaging showing patent portal and hepatic veins. So this patient liver biopsy showed idiopathic non-cirrhotic portal hypertension. Biopsy itself cannot diagnose, can't say it's idiopathic, but having excluded other condition, ultimate diagnosis was idiopathic non-cirrhotic portal hypertension. It shows obstructive portal venopathy, nodular regenerative hyperplasia, and incomplete septal cirrhosis. And it's very important because this particular entity carries a better prognosis than cirrhosis, because the liver cells, hepatocytes, are relatively spare, they are normal. So problem is mostly pre-hepatic. Now we then next discuss generalized edema without increased hydrostatic pressure. I said this generally due to, not generally, due to reduction in colloid osmotic pressure, right? And due to the main contribution comes from albumin, right? So when there is albumin, reduction in albumin, but generally looks for proteinuria, evidence of CLCD, because those are two other commonest, proteinuria and liver disease. If there are no proteinuria, tendency is to diagnose chronic liver cell disease, right? Because these two being the commonest, right? Now, there was a lady who came with a diagnosis of renal edema. She had low albumin, mild proteinuria, about 500 milligrams over 24 hours. ANA and anti-dsDNA were positive. Renal biopsy showed very minimal change. So this was diagnosed as minimal change nephrotic syndrome, and So generalized edema and ascites, very low albumin, trace albumin in the urine, and she had lymphedema as well. So common feature being low albumin with non-significant proteinuria with normal liver functions. So as medical students, again, right, any deficiency can be due to one of a few reasons: decreased intake, decreased digestion, decreased absorption, decreased production, and increased loss. With regard to albumin, the increased loss can be either renal or extrarenal. When you say extrarenal, dermal or gastrointestinal, right? Extensive eczema, burns, you can lose a lot of protein through the skin and through the kidney, nephrotic, and the gastrointestinal tract is called protein-losing enteropathy. So as you can see, the poor intake can easily be excluded in a normal person, adult, right? It's very rare to get protein malnutrition. Compared to very young people and old people, where the food can be restricted, they have to depend on other people. Reduced digestion, there'll be evidence and poor absorption and decreased production in the liver, so there'll be evidence of liver disease. And increased loss can be if there is no external loss, as in skin diseases, or renal loss, as in nephrotic. Then gastrointestinal protein-losing enteropathy can be extremely difficult to diagnose. Other two can be excluded quite easily. And so if a person has generalized edema and there are no evidence of renal loss or any evidence of liver disease, always think of protein-losing enteropathy. Now, I have had 2 cases of SLE presenting with PLE and 1 case of generalized lymphangiectasis. And PLE confirmation is difficult because the gold standard is fecal clearance of alpha-1 antitrypsin. You have to collect stools for a period of 24 hours, which is not a very pleasant task. So it's done by a process of extrusion. And we reported this patient, systemic lupus erythematosus, presenting with protein-losing enteropathy in a resource-limited center, a case report. And this patient actually first presented with generalized edema and low albumin, normal renal function and normal liver function. So we assumed it was PLE and did an endoscopy and biopsy, duodenal biopsy, which showed lymphangiectasis, right? And we thought it was the case of primary lymphangiectasis leading to protein-losing enteropathy because he didn't have any stigmata of SLE at presentation. And we didn't actually even think about SLE because there are no other features. And didn't know that PLE can be associated with SLE. 3 years later, he came with the typical rash of SLE and all the other features, arthralgia, the rest of it. And when we searched at that time, there was an association with SLE, only realized that it's a well-recognized association of SLE. And subsequent to it, I think another from Batiklo, Eastern University, there was another case report. So protein-losing enteropathy is a recognized but rare presenting manifestation of SLE, and diagnosing protein-losing enteropathy in resource-limited center is challenging, but it is generally done through an exclusion of other possible cause of hypoalbuminemia. And that's another case of interesting case that we move away from edema, right, to neurology. 72-year-old lady admitted with headache, generalized aches and pains, and insomnia. Seen by a neurologist for the headache. And asked to see regarding, I was asked to see regarding other complaints. So generally, when the subspecialist sees, fortunately, they ask general physicians to have a look as well to see if there are any other general issues. That's how I got involved. And patient developed recurrent GT, generalized tonic-clonic convulsion, 3 days later and went into status. Biochemistry, MRI, brain were all normal. Controlled with medication, started on long-term anti-epileptic drugs. but continued to have insomnia. And very important, say how important the history is. History revealed that patient had been on long-term diazepam and stopped by the neurologist on the day of admission, saying, don't take diazepam for such a long period. It's a bad thing. There are better drugs for to be used as sleep inducers. So it was a typical case of diazepam withdrawal fits, right? No amount of investigation would have told you that the fits were due to diazepam withdrawal unless you went through got a proper history, because EEG is going to be not going to tell you that the patient was on diazepam or not. Other biochemistry, nothing, right? So again, reiterate the importance of taking a proper history, having a little patience to listen to the patient's history. And then another interesting case, a lady with chronic diarrhea. 72 years, long-standing type 2 diabetes mellitus, no hypertension, no dyslipidemia, presented with the watery diarrhea, no abdominal cramps, weight loss or vomiting, was on glycoside, metformin, and atorvastatin, good diabetic control, HbA1c of 6.7, hemoglobin 10.2, MCV 95, WBC 4,500, and platelets 140,000, little mild pancytopenia with a high MCV. Mild macrocytosis, CRP, ESR fairly normal, normal retic count, marginally low, vitamin B12. Liver, albumin 3.5, globulin 3.2, ALT, AST marginally elevated. Alkaline phosphatase gamma GT normal, kidney normal, stool separ and culture normal, amylase lipase normal, ultrasound abdomen normal, seen by a gastroenterologist, suspected inflammatory bowel disease, did a colonoscopy with visualization of terminal ileum and biopsy, and macroscopically suspected Crohn's, and biopsy was taken and started on prednisolone 40 milligrams once a day. Subsequently seen by a general physician who continued prednisolone, biopsy report came normal. He relied on the macroscopic diagnosis made by the gastroenterologist and ignored or didn't see the report and continued steroids and added azathioprine. Patient continued to have anorexia, diarrhea, and weight loss. By then, she had developed many features of Cushing's as a result of large dose of steroids. That was the time I saw her and repeated all the basic investigations similar to previous ones, but the HbA1c was 10.5, now on twice a day, 70-30 mixed-start insulin. One thing was clear, definitely not inflammatory bowel disease. Prednisolone quickly tailed off and azathioprine stopped. A simple thing was done and the patient became completely better. Stop metformin. In 2 weeks, patient was absolutely normal. So there are enough proofs, right? Metformin dose and macrocytosis and mild pancytopenia and reduced B12, indicating that B12 is causing these things as well, B12 absorption, right? So the problem is he did the right thing by doing the endoscopy and biopsy, but the person who subsequently saw the patient ignored the biopsy report and relied on the diagnosis made by the specialist gastroenterologist. That is the range I have been telling you, right? If you don't challenge, if you accept full-heartedly the diagnosis given by specialist, and you are going to get into trouble. And another interesting one, this one I saw about 2 days ago. 53-year-old farmer with the history of no smoking alcohol, anorexia, cough and dyspnea on exertion and chest pain. Sent her to a district hospital where there's a cardiologist, and he did a primary PCI to LAD on the 12/4/2022. And in spite of that, he continued to have symptoms, and he did another one On the 26/5, then that time PCI to RCA. Type 2 diabetic for 8 years on metformin 2 TDS and Diamine 5 milligrams PD. Continue to have symptoms even after the 2 procedures. That is anorexia, cough, and weight loss. Obviously, and anybody would think of pulmonary thing and do X-ray, especially diabetic with weight loss and cough. And this is what I saw, done on the 30th. 2 PCIs, right, never did X-ray. So that is because you didn't follow the basics. So history, examination, and investigation, not investigation, and more investigation. Stick to basics. Take the history yourself. Focus clinical examination and order appropriate investigation and interpret lab results carefully. Don't let your independent thinking be influenced by diagnoses made by other people. Everyone makes mistakes. Some specialists tend to confine themselves to their own field, no holistic approach. So my message is stick to basics and think simple. Thank you.
Thank you very much, sir, for that illuminating lecture. It had many lessons for us as specialists and young specialists in internal medicine. And we really appreciate the time you took to share your wisdom and knowledge with us. May I now call upon Dr. Ganaka Senaratne to kindly present you with this plaque. This is in appreciation of all the services you have rendered to the medical profession over the years. Thank you very much.
Thank you. Thank you.
Thank you. I'll just wind up by giving the vote of thanks. Thank you, sir, for spending your valuable time and giving this lecture to us today. And to Dr. Harsha Satish Chandra for nominating you and helping to coordinate the activities. And our sponsors today, Searle Pharmaceuticals, for the support given. And to the audience, we had a big audience today for joining us. Thank you very much.
Thank you.